Okay, let's get going at 7:01. We've got doctors, a lot of doctors on the phone this morning, and we want to get going and get them back to their clinics and their patients. So good morning, everyone. It's Bridget Mettler here at the Doctors of BC, Doctors Technology Office, and welcome to our virtual care quick start session. We pulled this together rather quickly, and we'd like to thank Dr. Christine Sandborg and Carol Rimmer for helping us out with this session today. Next slide. I don't know who's running this slide deck, but can you move to the next slide?
It's Christine, yeah.
Christine. There we go. I'll do the housekeeping this morning. So again, if you're just joining us, welcome everybody and good morning. There is a control panel at the bottom of the Zoom webinar. Everyone is on mute because there are just so many of you this morning, and you know that many barking dogs will really be disruptive. So if you do want to speak, you need to raise your hand. Everyone is on mute, as I said. So if we unmute you and you're muted on your own side, it might be a double mute. So be aware of that and ready to unmute yourself as well. So also, I'd like to say, if you look at the bottom of your screen, there's a Q&A box. That's where we're going to capture all of your questions. If we do not get to all of your questions, we have staff that'll be following up with you. So don't worry if we don't get to everything today, we will be following up with you. And there's also a chat feature at the bottom of your screen. There's a chat box. If you click the chat box, that's for technical issues. So if you're having any technical issues, we can help you there. But please put your Q&A in your questions in the questions box. You can also vote up. Nancy's got a really good question here already this morning, and a few people have already done a thumbs up so that we know that that's an important question rather than having to repeat your questions. So I hope I got everything here, and we're going to hand it over now. If you go to the next slide.
Bridget, there's a request to turn up your volume. You're having trouble hearing.
Okay, thanks. And there we go. Over to you, Carol.
Great. Good morning, everybody. For those of you who I don't know, I'm the director at the Doctors Technology Office at Doctors of BC, and welcome to our webinar. I've never seen this, it's unprecedented. We have 862 people sign up for this webinar. We normally get 30 or 40, so it's incredible. Obviously, there's a thirst to know more about virtual care to deal in particular with this crisis, but hopefully you'll find the tools useful and you will continue to use virtual care going forward. So I just want to let you know that we have been through Doctors of BC working very closely with the Ministry of Health and PHSA so that we have a consolidated approach to how we're addressing virtual care and all of the technology issues. I don't deal with other stuff. We deal with the use of technology in practice, but so that we have a consistent and consolidated approach to how we're doing this across the province. So what we're trying to address today, as Christine said earlier, this is really a how-to guide for how do you get started in using virtual care. It is not specific to COVID, although we know that there's an urgent push because of the COVID situation and the fact that we want to keep our patients and you safe when you're trying to care for your patients. So being able to do it from a distance is a great opportunity. But having said that, we also know that there are some things that we're going to allow, if you want to call it that, you to do that you may not do under normal circumstances. And we'll get into that in a minute. But we want to continue to evolve this. So even when the crisis dies down, we'd like to stay in touch with all of you as we start to figure out, okay, under normal circumstances, what does this playing field look like, and how do we make sure that we are doing the right thing going forward? So next slide, please. So in this session, we're going to cover what virtual care is going to be like in this time of COVID. We're going to go through the 5 steps of how to get up and running quickly, about getting your patient contact information, patient consent, virtual care tools, how to set up the visit in terms of workflow, billing, but I do want to remind you that the focus of this session this morning is not about billing. There will be another billing webinar on Tuesday evening, but we will touch on billing today, and then any other supports, and then take some of your questions. It will be very hard because of the number of people on the phone. to have a real discussion, but we'll do our best. And as Bridget mentioned earlier, please type all your questions in there. And if we don't get them online, then please stay patient and we will get back to you with answers. And we will try and put together an FAQ document that we can post online for everybody. On that note, I'd like to turn it over to Dr. Christine Sambor. Christine is one of our first virtual care peer mentors. Christine is a family doctor on the North Shore. She is on the board of the North Shore Division of Family Practice, and she also sits on the Digital Health Initiative Pillar 1 Steering Committee for Patient Empowerment. And so on that committee, we deal with things like the Citizen Gateway, like virtual care, and the types of things that we can put in place with technology to support better connection with our patients. So over to you, Christine.
Good morning, everyone. Thank you, Carol. I just wanted to start by thanking Carol Rimmer and the team at DTO for helping put this presentation in really very short notice. Of course, DTO has already been working on some virtual care resources, but rather than the slow, methodical way that it was going to be rolled out, they've adapted quickly to the urgent demand for virtual care. There's also a team of peer mentors in the background that have all contributed both in the development of the toolkit and this presentation. So thanks to all of you. And finally, thanks to everyone for sharing your early morning Thursday. I hope you have your coffee ready, and I'll probably talk for about 30 minutes and then we'll have some time for questions. Just to give you a bit more background, I am a full service family physician on the North Shore, so we're really feeling like we're in the trenches these days. I work with a group of 13 physicians. We went from 3 physicians using telemedicine to all 13 of us in under a week. So a bit of a crash course. I've actually never seen staff, physicians, and patients align so quickly around a concept. So I'll walk you through some of our experience. I wanted to start off just talking about virtual care in the time of COVID-19. So in the words of the great Dr. Bonnie Henry, these are extraordinary times. We are now in a state of emergency. We're asking our vulnerable patients to shelter in place, and I think we really need to do all we can to keep our patients safe and at home. And so this has really changed the way that we've used virtual care in the last week or two. So as far as definitions, virtual care is actually any non-face-to-face communication with your patients. So this can include your telephone call, email, text, telehealth, whatever, secure messaging, WhatsApp. I think one of our main messages today is please use whatever works for you and whatever works for your patients, and that you might need a toolbox of resources to offer for different patients. So in the last week or two, things have rapidly changed on the North Shore. We're seeing that we're using the telehealth in particular in 3 different areas. So first of all, specific to the COVID patients, early on we recognized that the telehealth and telephone were a great way to screen patients, get most of their history. If we did need to screen them, then we would minimize their time in the office. To be honest, as we got a bit more busy, I switched over to telephone because I can still make 2 or 3 quick telephone calls in between patients rather than setting up the virtual care telehealth. And so that's really the message is, you know, use what you can in that moment. Now we're actually just using the telehealth a lot to, we're asking people now to stay at home. So it's a lot of education about self-isolation, should I, shouldn't I, sending along that information. The other thing that's come up is monitoring patients that are already on self-isolation. They're certainly still experiencing either unrelated medical issues or we need just to monitor how they're doing from a respiratory perspective. And I think we're just starting to understand the psychology of quarantine. So people are so appreciative to see a familiar, trusted face. And I've had patients burst into tears because they're isolated at home, they're super anxious, they're following their Twitter too much. And so there is just something about that, that visual connection that I think has been very helpful. Second area is vulnerable patients. And this is where I really see the aha moment with most of my colleagues. Even a couple weeks ago, we were anticipating that there is a point at which we are really going to ask our vulnerable patients to stay at home. And every time we ask a patient to leave the safety of their home and come out into the community to talk to us, they are potentially going to risk being infected. So it really comes down to first, do no harm. The other interesting thing has been physicians in quarantine. So we are, again, a group of 13. We've already had 2 physicians and 1 staff member go on precautionary self-isolation, myself included. So I have a very supportive group of colleagues. And I have to say, having that ability to very quickly change my days over to virtual made it very easy for me to err on the side of caution. And I feel still very connected with my patient population. We've all been told that this is a marathon, not a sprint. And so our group is already trying to think about future manpower issues. I suspect that many of us will have to be isolated either because of illness or because of contact. So we're trying to think about in our group, if somebody's otherwise well at home, how can we redirect some of our virtual care traffic to that person to ease the office, and how do we get patients seen if they need to be seen? So, so the telehealth landscape is looking a lot different just in the last 2 weeks. Okay, so we're going to go on to all the different steps that we need to typically take to get ready for telehealth. So step number 1, gathering information, so email and mobile numbers. And the email is important because most telehealth vendors will either ask you to send an invitation to the patient by email or send them a link with an appointment time. But just to take a sidestep, we found having the emails so valuable. We did figure out how to start sending out practice broadcast emails. And we've sent about 3 or 4 of them now. And so early on, just really sort of frequently asked questions about COVID. We've done one about what is self-isolation or what is social distancing, but always with the top part of the email, really stressing that we want people not to come into the office if they've got fever, cough, and outlining our specific strategies for triaging patients. So we've had tremendous feedback, positive feedback from the patients about that. And I think it's kept us safe, kept the patients safe, kept our staff safe. So in fact, some of our doctors have realized that this is so useful that they've hired people to go through their list and actually call people to get their email so that they can be included in this communication. So it's a great task to do for any staff member that might be on isolation. The mobile number is important as well. It's nice to have it handy for technical issues when you start your telehealth visit. Sometimes people have trouble with their audio, particularly if they're using a webcam. So I've had it where I'm using the telehealth for the visual and I'm actually on the cell phone for the audio. So that's often helpful. We do get into the problem that we do need to get the message out to patients that if we're calling, we're often on a blocked number. Although again, extraordinary times, I've unblocked my phone so many times in the last 2 weeks, I'm sure I'm going to have to get a new cell phone number at the end of all of this. But patients have been generally very respectful of not calling unless instructed. Okay, so that's step number 2. Step number 2 is obtaining patient consent. If I'd been giving this talk a month ago, I'd certainly be focusing on this particular slide. So most of us are using the CMPA consent to use electronic communications. We have a link here in the webinar. I do suggest that people actually check off all the electronic communications, even if you're not using them yet, so you don't have to go back. And so and redo it. So it includes email, text messaging, video conferencing, website portals, and social media, which we don't use. If you're going to go through this process, it's very handy to be able to color code or somehow mark which patients have already gone through the process, so you can quickly see them when you go through. The main message today, though, is verbal consent for telehealth is acceptable. And in fact, if we don't want people to not provide services because they haven't gone through the 3-page written consent. This is an urgent time. We want to keep people out of our office. And so it is completely acceptable to just do a verbal consent with your patients. And when you think about it, we, even with telephone calls, we don't necessarily start with a privacy and security statement. Talking on the phone has been pretty normalized. There is some implied consent there because patients are giving you their email, they're answering the invitation for telehealth. But if you want to explore that verbal consent further, it's actually in the toolkit. There's some wording that I think came from Ontario that's been looked at by the CMPA. The basic points is patients really should be in a private setting. They should, for best practices, is that they should use their own device and just secure on the on their Wi-Fi. And then just letting patients know that they may, after all of this, need to be seen anyways in the office. So virtual care tools. Again, I'm going to refer people to both the Quick Start Quick Guide, which is a quick 3-pager, and then there's a more comprehensive toolkit. There's lots of different vendors out there. There's lots of things that we can be thinking about as far as texting, emailing, video conferencing. Some of the vendors, some of the EMR vendors have it inside their EMRs. For the most part, you're using a second vendor, and I'll chat a bit about that. Lots of people are using DoxyMe right now. We just happen to use Medeo, so I'll walk you through a little bit of that process. But again, the message is use whatever works for you. Even if it's FaceTime or Skype or whatever it is. So whatever's going to work for you, whatever's going to work for your patients. And the other thing I wanted to highlight is just the MailChimp. So it was actually shockingly difficult for us to figure out how to send broadcast emails. Our EMR vendor does not support that. So we did manage to export a spreadsheet into MailChimp, and now we've got a nice email list ready for the broadcast.
Dr. Sambor?
Yes.
It's Bridget. We have a hand up, and we're just going to do a really quick check here just to make sure it's not an accidental hand up or someone has a very pressing question. Okay. Corbus, we're just going to pull you off mute, and if you're still muted, it's muted on your own side. Did you have a question? Corbus Smith? You're muted on your own side. Nope? Okay. Sorry, okay. Christine, we just want to make sure. Okay.
Well, carry on. I'm certainly happy to take any questions at any time, or we could wait till the end and have a robust conversation. Okay, so the next thing to think about is just your virtual care setup. And you can choose to do this at home or in the office. I actually do both. So prior to this, I would do a half day on a Thursday from home. And I've also started offering it at the end of the day at the office. And for those situations, it's often people like, if I'm asking someone, they're coming in from Chilliwack to North Van, so I can really just talk to them about something, I'll offer them the virtual care. And it has actually increased access. So, adolescents that maybe don't want their parents to drive them to the office. So I have post-op patients, that's another one. So, so we have offered that in office as well. You need to decide whether you want to use a laptop or a computer with a webcam. Some of the webcams have speaker and mic capability. Sometimes you need to get that separately. I actually do both as well. So at home, I do have a computer with a large screen. I do have to run both the programs, both my EMR and my telehealth program. So I run them side by side. These days, actually, I've just been using my laptop, and it turns out you can, for what I'm using, I can toggle back and forth between the two EMR and telehealth. And when I'm in my EMR, the patients can still see me visually, so that seems to work well. But other colleagues that actually have two different laptops set up, one for their EMR and one for their telehealth. So whatever you think is going to work for you. If you're working from home, you may need to think about, do you need a printer, a scanner, a fax, an e-fax? So thinking about your workflow, and I'll cover that more under physician workflow. And then just a note to think about your physical space. So take a look back, see what patients you're seeing in the background there. So the next step is MOA workflow. And as we all know, if you want to make any kind of change in the office, it's always good advice to start with your MOAs. They're just a very valuable member of the team to get things rolling. In this case, there was no problem. The MOAs get it. They get the sense of urgency. They also have a longitudinal relationship with the patients. They want to do whatever it takes to keep them safe, and they recognize that keeping some patients out of the office will keep them safe as well. So that's been the easy part. So typically the MOAs need to create a different kind of appointment type within our EMR. I still actually put my video visits into my regular day sheet. We've created a video appointment time. Just easier for me to click into the chart as I'm going through my day. Now that we're a bit more comfortable with that, we've opened that up to online booking, and I have to say our experience so far is patients have used that online book, the telehealth video appointment quite appropriately. The next step is really having a conversation with your staff about triaging patient suitability. So in the past, we've had lots of conversations about, something that doesn't need a physical exam. In the beginning, mostly I was doing follow-ups. It's often initiated by me. I might say to a patient when they're in the office, well, we probably need to see each other in 2 weeks. Why don't we do that virtually? When I got results in, I would task the staff, to come in or virtual visit. It's also been very helpful when patients have long lists, because I can say, well, it looks like you have a long list today. I see these 3 items need a physical exam. Maybe let's see what we can do in the interest of time to do this, this, and this. And then perhaps we can do a virtual visit and follow up with the list. So that's been really, really helpful. Again, it's extraordinary times. So I would actually now turn this question around, and I would actually ask the question, is it appropriate? Is it suitable for this patient to actually come into the office? Is it safe to do so? Is an exam required? There's certainly jurisdictions where up to 80% of primary care visits can be done virtually. And so we want to make sure that we have a good reason to have patients, again, coming out of the safety of their home into the office. I put patient instructions in parentheses, partly because, again, I don't want this to slow you down. I don't want anyone to say, oh, we don't have a fancy brochure, and so let's wait till next week to get started. We do have a how-to guide. Generally in there, we put all the technical requirements and frequently asked questions. We make some comments about, being in a private space. So we've all had situations where people have telehealth logged in from, Starbucks. One of my colleagues said someone that was actually physically driving when they logged in. So a bit of patient education about, the suitability of their space. We generally tell patients to log in about 5 to 10 minutes before their visit. And that will put them in a virtual waiting room, and it will run them through an audio-visual check. So they're ready for that. We also tell them it's like being at the doctor's office. The doctor might not be there right on time. So just hang tight in the virtual waiting room. And if there's any technical issues, we will contact them on their cell phone. So in an ideal world, we'd have this sort of sheet to either email or physically give to patients as we register them. There's certainly lots of resources through DTO, and the vendors often have some examples of that. And if you're able to do that, that's wonderful, but don't let it slow down the process. And by the way, I have to thank the DTO for this visual. I'm sure we're all really wishing we could do our COVID swabs as indicated in the picture there. Okay, so the
Dr.
next
Sambor, we have another hand up. I'm just going to do a quick check to make sure, again, it's not just an accident. But we don't have a name. All I have is Galaxy A70. So whoever Galaxy A70 is, we are unmuting you if you have a quick question for Dr. Sambor.
Yeah, you are now unmuted on our end, so please go ahead.
If you're Galaxy A70, send us a chat and we will try to get you off mute. Go ahead, Dr. Sambor.
Thank you. And don't be shy. Ask some questions on the question and answers for sure. Okay, so the actual workflow of my day. So if I'm at home and doing my my telehealth visits, I sit down. I have to remotely log into my EMR. I need to log into my video. Again, I tend to just toggle back and forth on my laptop. So I'll show you the specific workflow in a second. So you start the interaction with the patient. Don't forget to look at the camera every once in a while so you look like you're looking right at the patient. One of the things to think about is to be aware of who else might be in the room, and so it's not uncommon. So halfway through interaction, I'll hear the spouse kind of piping in from off camera. So I don't mind that, but if there's certain situations where you'd like to know who's in the room, you certainly can ask. I actually had an interesting situation where I had a patient sitting in his living room, and every few moments there was another family member kind of coming into view. And then it turns out that the whole family was there, and I didn't get the memo, but this was an intervention. And there was really something touching about, this patient sitting in the comfort of his own lazy boy wrapped around his family, and he was able to disclose information that he may not have been comfortable telling me by himself in the office. So you'll certainly have other people in the room with you. Again, a quick reminder that you might want to do a bit of verbal consent as well. And then your visit is like any other. So the history is the same, and you can do a physical exam. You can get a little bit creative with that, and certainly do a lot of dermatology, musculoskeletal exam. There's a lot you can do with range of motion. I'll sometimes actually use a partner and have them help me with impingement testing, that sort of thing. I've done checked for nystagmus with telling the patient pretend I have some virtual fingers and move your eyes back and forth. And sometimes the patients will just pick up their phone and they'll say, "Hey doc, I want to show you something," and it's amazing what they'll show you. Usually, thankfully, it's just they're showing you their toes or something, but they'll show you all sorts of rashes. And so patients have quickly accommodated to this technology and found very creative ways to show me what they need to show me. I think the biggest all the questions that I get is more about this workflow from home. And actually, I think this is relevant even if you're doing telephone calls from home. So this is, what do I do during and after my visit, mostly in terms of what do I do to send documents, so prescriptions or requisitions and things like that. So of course, if you're at the office, you can task your MOA as you normally would. And when I first started, I actually did something similar. So if I had a patient that had needed an X-ray requisition, I'd write it up in my EMR, I'd leave it there, task my MOA would go in, she'd print it, she'd give it to me, I'd sign it, she'd send it. And so it was more work for the MOA, less work for me, but I was able just to focus on the technology. As time has gone on, and certainly now that I'm self-isolating and can't come in and sign all those documents, it's nice to work towards being a little bit more independent. So some of the things to think about is how can you sign documents? So our EMR does some auto signing, but for prescriptions and whatnot, that's not available. So I use a print to PDF function through Adobe, and you can put a wet signature on there, and then I import it back into my EMR. You should also look at, can you do e-fax directly from your EMR? Would you use a physical fax? A neat feature on a number of the virtual care platforms is you can actually attach documents directly in the encounter, so patients can pull those off. And you can certainly email, but then I would actually be a little bit careful with your consent because email really isn't secure, and so you have to be very careful about what you're sending. However, again, if it's an urgent thing, then I think as long as you're getting some verbal consent and the patient understands why you're doing that, then I think that could be acceptable. And of course, you always have a plan what to do if the patient actually needs to be examined. So in the past, I would do my virtual visits in the morning, and that way, if I did need to see a patient, I could do so in the afternoon. So I'm just going to go through some screenshots from Medio. It's the platform that I use, so I'm familiar with it. And these are screenshots from their training training videos. So these aren't live; these aren't actual patients. So when I log in for my day, this is what I see. What they haven't shown you is in the right gray blue column. We usually start to see little pink boxes pop up of the patient's name, and those are the patients that are sitting in the virtual waiting room. Annoyingly, it tells me how long they've been waiting. Patients can access this either through a mobile app or on their computer, and they also are put through an audio-visual check before they're put into that waiting room. So when I start the conference, I press that start conference button. It runs me through a little bit of an audio-visual check as well. And then this is what I see. So for those of you that don't know me, that's not me. That's again a screenshot from Medio. Typically, you'd see both boxes there. And again, remember to look at the camera every once in a while. What this screenshot is showing is just the chat feature, and quite useful. So for having audio visual, I'll sort of use some sign language pointing down to the bottom of the screen, like open up your chat box, and I'll walk them through their audio or their technical issues. Also, it's my sticky note. So if I want to give somebody some information, something over the counter, I can just write it in there. Patients can access that at a later time, and it's sitting there. The actual video is not recorded in any way, but any kind of chat and documents that are left there, patients can access later. And then there's the little paper clip there at the bottom that's been very helpful, and it's actually two-way. So I've prepped my patients if we're having a hypertension talk, please do your home readings. They can either give it to me verbally, or if they want, they can attach that document and I can import that into my EMR. And it's certainly helpful for sending things to the patient. I find that some of the forms and things, it's kind of finicky. I'll often do that after the visit, but what I've been sending a lot right now is just that guide, how to self-isolate, and that's just a quick click. I've got it in a folder, and I'm sending that when we're having those conversations. So that's it. And I have to say, it used to crack me up that every advertisement for telehealth usually had a physician with a stethoscope wearing a white lab coat. And I thought, oh my goodness, how redundant. But it's actually not so funny anymore, because in the office, last week, I've been going from face-to-face to a telehealth back to face-to-face. So I'm sure I've been caught out. I think we're all trying to find our old lab coats, and I certainly have been caught out wearing my stethoscope for a telehealth visit. And these days, because I'm having the conversation, look, we're really trying to keep you out of the office. I'm ending a lot of my telehealth and telephone visits, just saying, look, I'm always a phone call or a telehealth visit away, and making sure that patients still know that we will manage their care and that we will remain connected. So that's the virtual visit. So I'm going to briefly talk about billing, and of course there's the billing webinar on Tuesday. But I think that the actual billing for virtual care is fairly straightforward. So you can see there's a 13037. That's the typical telehealth that most primary care physicians will be using in the office. And I actually use quite a bit of the 13038 now, and that's the counseling visit. I found it actually quite useful. Same rules apply. So you have to have the right indication. The patients have to be under significant emotional distress. You do need to document appropriately and have the start and the end time. So it's kind of neat now because we have 4 of our 120 visits per year. We have our mental health visits per year. And now we have 4 telehealth counseling visits per year. And so we can really check in with high-risk patients really on a monthly basis. The codes below are out-of-office visits, and those are for people that are in an accredited telehealth facility. So this might be very relevant for our rural colleagues or specialists, but we would not use those in the office. So as of March 16th, the telephone consult, so for physicians now, we are able to bill the 13037, even if we're connecting with someone by telephone. We have clarified though, if you are using an RN or an LPN to do some of your phone calls, they should continue to bill the 14076. So the new coding around the telehealth is only if the physician is doing it. And of course, there's also the 14078, which is more email, text, or if your MOA relays some information onward. If you start off with a telehealth visit and then you need to see the patient that day, then you cannot bill for both. You need to just bill the appropriate in-office fee. And there's probably not a lot of codes for specialists that I'm not familiar with. So there are resources through DTO, and if you have specific questions, I think you can, they'll follow up with you. So that's the billing.
And before we leave the billing, I see there's a lot of questions on billing coming in through the Q&A. It's Bridget here at the Doctor's Technology Office. We will follow up with your questions, our staff. There's also a billing session on Tuesday. We will get the details of that session to all of you today. So you will get a link to that today from us to sign up for that session.
Great. Okay. So I just wanted to touch briefly on a couple of communications that have come into our inboxes over the last few days. So a few days ago, we did get an update on telemedicine from the College of Physicians, and they actually do have quite a nice document that outlines our responsibilities. The main message is, as physicians, we're expected to provide the same level and duty of care, whether we're seeing patients face-to-face or virtually. So they had some important points. So having the ability to provide a face-to-face interaction in a short period of time is important if it's necessary. They're exercising caution when providing a prescription to patients that you haven't examined. And a really important point is that they do say that you can only prescribe opioid and psychotropic medications if you are in a longitudinal relationship with that patient and if you have recently examined that patient, or if you're in direct contact with a longitudinal physician. They're also just reminding us that if you're doing a referral to a specialist, please make sure that the patient is worked up adequately and managed in the meantime. And I think it all comes down to context and documentation. I've certainly had people in isolation, and I've had conversations where I say, well, ideally we would do X, Y, and Z, but since we can't have you, it's probably not worth you leaving the home right now. So we're going to do this for now. And here are the situations in which you need to get back to me. And I think if you're documenting all that, that would be helpful. We also got a communication from the CMPA late last night. So again, walking through some of the issues that they're seeing. There's a frequently asked question section. One interesting point that I saw is that jurisdiction, right? So if there's someone that is from your jurisdiction that is stuck overseas, and you provide a telehealth for them, then that they're saying that will likely be something that they would support. Obviously, someone that's living overseas that is not in your jurisdiction, then that would not be helpful. You might just want to have that standard conversation about about jurisdiction with your patient, if they're stuck out of the country. So that's it. So you can do this, and we can help. And This slide is actually from an old presentation, pre-COVID. It was a bit more lighthearted. I really miss the old normal. If I were to modify this, I would say you can do this, and we all must do this. I think we need to use whatever technologies we have at hand to keep people home if we can, to protect our vulnerable patients and really our whole community, and really focus on first do no harm. So you can do this and we can help. There's lots of help available out there. So through the Doctors Technology offices, the peer support program, divisions of family practice, and I'm seeing that all those supports are really aligning. And so I think Carol's going to talk a little bit more about that. So just want to finish by saying good luck to everyone on their virtual adventure, and I hope you all stay healthy, connected, and well supported in the coming months. Thank you.
Thanks, Christine. So if you can go to the next slide, that would be great. So we are going to open it up to some questions. We may have to have that facilitated by Bridget, and she'll take some of the questions that have come in the Q&A box, because with this larger group, it's going to be hard to just open it up to have a dialogue. But before we do that, I just wanted to share with you that we will be providing ongoing communications. So please check the DTO page on the Doctors of BC website, and or through the front page of the Doctors of BC website. There are COVID updates, and there will be links to all of our DTO materials in there for anything virtual care related. So in addition, as I mentioned earlier, I'm on daily calls with the ministry and PHSA and other partners. So we will keep you up to date on what's happening on other fronts as well. In terms of the virtual care peer mentor program, we are gaining traction. We had this as part of our plans for the year, and we've had to ramp it up within a couple of weeks. So please bear with us and be patient while we get things going. But we will have physicians and MOA peer mentors available to support you if you need that one-on-one support. We will continue to have learning sessions and workshops as we go through this, this collective learning as we move more into a virtual care world. We are partnering with the practice support program as well. So, but in order to facilitate this and make sure that we stay coordinated and we're not creating chaos in the system, we're asking that you please contact the DTO info, and soon we will have a phone line available for you to call as well that we'll make available to everybody. And we will be the sort of central point of triage, or help desk, I'll call it, to facilitate and triage your requests. So whether you need technical help with your system at the office or at home, or if you have billing questions or you need in-practice support, whatever it is, we will link you with the appropriate people to address your need. So on that note, I think that's all I needed to mention, and I will turn it over to Bridget to help us facilitate some questions.
Wonderful. Thanks, Carol, and thanks, Dr. Sambor. We really appreciate this and you both pulling this together very quickly for us. As Carol mentioned, this information is changing sometimes hourly, and our team is trying to stay on top of it. So do check the websites every time you want to get an update for the most recent information. There are a lot of questions. See one hand up for Kazim. We're going to get you off of mute. But there are some themes that are coming in, Carol, which I'm sure are not going to surprise you. If you are writing questions in the Q&A box, our staff, if they do not get to you, they're answering live as we speak. If they do not get to your question today, we will follow up with you after. But I have noted a few themes such as privacy and security. Carol, which can we really use? Some wet signatures. How do we do that from home? Lots of questions about billing. There'll be a session on Tuesday. We'll circulate that. How do we work with the college and the CMPA? And which platform is best? So I'm going to get Kazim off of mute while Dr. Sambor and Carol think about some of those questions and see if we can get him live.
Yes, so you're unmuted now.
Kazim?
Hello?
Yes, we can hear you.
There you go.
Okay. First of all, I would like to thank you all for arranging for this very informative session. but still I have some technical challenges. First of all, I would like to know which app, I would say, can I use to do some video conferencing, video contact with my patients? Is Skype acceptable? Is WhatsApp acceptable, or are they have their own problems in terms, especially legal aspect of usage of these softwares? Thank you.
Okay, I can try and tackle that question. So as Christine mentioned earlier, these are extraordinary times. So I'm hoping that when we get back to the new normal, whatever that looks like, we can take a more concerted look at all of the apps and tools out there, work with our partners at the Ministry and PHSA, and come up with, here's some recommendations for how we should move forward as a province together, rather than leaving it to everybody individually to have to make a decision on their own. But right now, because of the circumstances, we just want to make sure that you can connect with your patient. That is first and foremost. So whatever you feel you're comfortable using, whatever you feel that your patients are going to be able to use, that's okay with us. I have had conversations with the ministry in terms of privacy and security and those types of things that we normally look at as very strict requirements for using tools like this. We are relaxing those things and saying patient care is first and foremost. Use what you have to, and if we have to beg forgiveness after the fact for any privacy and security issues that come up, then we will do that. And I heard that directly from the Deputy Minister. So please feel free to use what you need to. But going back to what Christine said earlier, what's critical is that you make sure that you're getting that consent from the patient.
Okay.
Typically with virtual care, it's essentially implied consent. They're not going to be on the phone with you or on an app with you if they don't want to talk to you. But they need to know that we need to know, and you need to document in the chart that you have got their consent to use this tool to connect with them.
Excellent. Thank you.
I would just add, if you're using your like FaceTime or WhatsApp or any of those things similar that, even when we're calling a patient by cell phone, I think it's also just important just to erase that contact information out of your phone after you talk to them. And some of these more formal virtual platforms, I think you'll find a little bit easier to use in terms of like the virtual waiting room and all those things. So I know a lot of people are using the DoxyMe and video, but yeah, sometimes for a patient, if they're super familiar with WhatsApp and they're intimidated by having to download a different app, if that's how you're going to reach them, that's how you're going to reach them. But we've hopefully highlighted to think about.
There are a lot of tools out there available, a plethora of them, and we do not recommend any one. You have to use what you're comfortable with. Some are paid, some are free. I would just caution you, and you may decide, for the purposes of this crisis, that you'll choose one of the free apps and just get going on virtual care. But ultimately down the road, you may choose that that's not going to have the functionality that you desire. And you may want to look at moving to something where you have a paid subscription. But for now, as Christine said, use what's going to work for you.
Thank you.
Thank you for that question. I don't see any more hands up at this exact second, but Dr. Sandborg, could you, and maybe even Carol as well, comment on another theme we've seen around the wet signatures? Working from home, how do you deal with the prescriptions, the labs? Like, how did you find that piece, or how are you handling it right now if there's a need for that?
I'm leaving that one to you, Christine.
Yes. So I know a lot of EMRs are now quickly looking at how they can incorporate that into their EMRs. Ours actually puts a signature on everything but a prescription. And again, I'm using a feature where I can print to PDF, and then Adobe has a way for me to do a unique signature for that. And then I'm just saving that, importing it back into my EMR. It's a bit finicky. So I think we should be working with the EMR vendors to find a way to allow us to do that right within the EMR would be very helpful.
Thank you. I see we've got another hand up from Brenda. As we get Brenda off mute, Another question that we're having is, Christine, for that consent form, are you able to delegate that to office staff? Are you able to get your MOA to get consent, or does it have to be the physician? That's a burning question as well.
So typically we get our staff to start with it. And if you look at all three, there's a couple of choices. Like you can actually say, you know, I like to communicate about this, but not about that. And generally electronically, we try to be very careful about any kind of sensitive information. So the staff will go through it with the patient. They're given it while they're waiting for me. And then I will go through elements of it, highlighting the important elements myself when I'm there. So, and then we scan it into the EMR, and then we have a way of color coding that patient to indicate that we've had that conversation with them.
Okay, I have
And
Brenda.
Brenda, we've got you up. Brenda, can you hear us? You might be muted on your own
Yes.
side. Brenda Lau?
Can you hear
There
me?
you go.
Hello?
Yes, we can
Hi
hear
there.
you.
Oh, excellent. Thank you guys for that talk. It's wonderful. We're a specialist multidisciplinary clinic in the community, and we've been running GMVs, group medical visits, as one of our major tools for pain neuroscience, fascia health, microbiome, all types of things. So my pointed question, because we've already moved to full virtual as well this week, is to confirm, because I talked to Tara yesterday, is that the GMVs are actually telemedicine billing appropriate as well. Can you please confirm that?
Carol, you probably had more conversations about this, but I think in that about billing, they said if there were any fee codes that specialists usually bill that they're now doing by telehealth, you can put a little note that you've done it by telehealth. But Carol, you might have had more specific conversations about that.
Yeah, that's about as much as I know as well, Christine. Leah, you're on the phone as well. Maybe if we can unmute Leah Harth, she's our billing expert from Doctors of BC. Maybe she can comment.
Okay, what was that question again? Sorry.
Can you hear me still?
Yep.
Yes.
Okay, great. The question is, and that's my understanding as well, is that if there are any existing fees that do not have a accompanying telemedicine code that's existing, then we put into the billing note the actual words telemedicine COVID, and that is what is going to be recognized as a equivalent telemedicine code for whatever fees. Usually, I guess it's mostly specialists, as I can see. The GP fees are quite comprehensive. So that's my understanding, is that GMV, therefore, when we bill it, is telemedicine appropriate.
Right. So any services that do not have a telehealth equivalent fee code, you bill the usual fee code. So for the group medical visits, you would bill that corresponding fee code for the number of patients in the session. And in your billing claim, insert the note service provided by telehealth. And that works whether you are doing it by telephone or video technology.
Yes, thank you so much for doing it all by video. Thank you.
I just want to pick up on,
You're welcome.
Bridget, I just want to pick up on a couple of things that Brenda was saying. You were saying that you've gone 100% virtual this week, and we're hearing that a fair amount. And so two things come up. I think I'm hearing concerns that patients are sort of showing up at their doctor's office and seeing the door locked and closed and saying, we've gone fishing, basically, or that's what they assume. We need to find a way for you to communicate with your patients to say, we haven't abandoned you, we've just gone to a new mode of care delivery so that we can keep patients safe. So that's one thing. And I'm working with the Doctors of BC communications team to see if we can create a poster that all of you could use to put on your doors. The other thing, though, is how are you, you need to consider how are you meeting your duty of care? So if there is a patient that needs to be examined physically, how are you handling that? Are you going into the office? Have you made arrangements for another colleague who is staying in the office to care for those patients? Just something to think about. I'm certainly not an expert in this. I'm not a physician, but we do need to make sure that that you are capable of still physically seeing a patient.
Am I still on? Excellent. So what we've done is that, in fact, we haven't closed down. So 100% of virtual meeting is all of our talk appointments, and a lot of the, and therefore 100% GMVs. We have right now the full bore of our interventional procedures and anything that requires hands-on. We're now going to start a rotating on-site interventionalist. In other words, we're trying to limit the exposures of the very few key specialists who are doing this work, yet is very important for the patients who are in pain crises. And finally, we also have our onboard physiotherapists as well. So we have very, very restrict entry clinic guidelines.
Yeah.
We've sent broadcast emails to educate our 2,000 plus patients. And so our website is a tool that we use. Our EMR is Input Health, and they have all that understanding right now. We've converted basically all the appointments that were procedure-wise into a virtual appointment, and it allows a patient to choose, do they still want to come in or not? And if it is not that urgent or necessary, then they are just doing a virtual appointment with the doc to examine next steps. And that's
Right.
why we're looking at the group medical visits right now as a huge form of support and connection for
Yeah.
our perioperative patients, our emergency patients, and our community GP physicians as well. So we're going to be expanding that out quite quickly today.
Great. Thank you, Brenda. So I certainly wasn't making a comment specifically about your situation, but just reminding people that this in general is something you need to think about. But that's awesome, the way you've organized yourselves.
Thank you.
I've got another hand up from Pamela. I think it's G, but print's really small. We're just going to get her off mute. But before we get to Pamela, Dr. Sambor, how do you handle right now, like what's your advice to a physician who needs to see a patient physically, like needs them in front of them? So, you know, do they delay? Do they put them off right now? Do they see them in the hospital? Like, what are you doing right now if you do find you need to see a patient in a physical?
Well, right now I'm not seeing any patients physically because I'm in self-isolation. But I think it's really important. We're still seeing patients in the office, and so some of my colleagues are there. But I think over the coming weeks, I can see us going kind of predominantly virtual when we can. And I think screening is really important. So if patients do have respiratory symptoms, to keep them out of the office. You know, that being said, I had a patient on self-isolation and her cough was getting worse, and she needed to be seen. And so we arranged for her. We're seeing all our respiratory patients at the end of the day to keep them away from the general population, and we get them to stay in their car, and we call them up and directly into the room. And she had pneumonia, so my colleague was able to examine her and give her appropriate treatment. So we have to remember that a number of the patients that we have that are self-isolating at home, they're still going to have pneumonia, they're still going to have influenza, and so we are still making arrangements to see those patients in the office. But I think strict triage and keeping those patients separate and keeping our staff and our physicians protected, I think is really important.
Thank you. And Brenda or Pamela, we're just going to get you off mute.
Yes. Hi.
Pamela, please.
I'm a psychiatrist and I haven't done virtual care before, but I'm trying to shift to that. My question is about the college guidance on not being able to prescribe psychotropics for people that have not been seen in person. Because I have people who are maybe, you know, not urgent psychiatric, more routine. I would like to be able to still offer them a service.
Mm-hmm.
Does that mean we can't do those initial assessments through virtual care?
And I think that we could certainly clarify that with the college, because you know, again, it's all about the circumstance. So if you have someone that you have not yet had a longitudinal relationship with because you are consulting, but there is an urgent need to start something, you know, I think you just need to document that explicitly in the chart. But that might be a point that we can clarify with the college. And as we move forward, I think we're gonna come into all these sorts of questions that we hadn't quite anticipated. So hopefully we can have a a community that can share some of those answers. And I have to say that I think we urgently need virtual counseling just in general, because there's a lot of people out there that are very isolated. So it'd be wonderful if we could keep our psychiatry colleagues working virtually.
Thank you. It's 8 o'clock on the button, and I know we promised to get physicians back to clinic. We are going to stay on the line for an extra half an hour, but we will let some of you go. I know Carol and I are working on possibly pulling together a few training sessions for you. I've seen some requests in the chat for, MailChimp or more details on how you do consent, how you're communicating with your patients, examples, maybe some on-demand training. I see pathways has been mentioned lots. And again, there's the billing session on Tuesday, which we will circulate to you and get all the details out for that as well. But Carol, I don't see any more hands up. You and Christine want to bring us home, and then we'll let everyone else off the line. And then we can continue on with some questions. Everyone's welcome to stay on with us.
Yeah, sure. So you're breaking up a lot, Bridget. Thank you, everybody, for joining us this morning. It's been a great session, and we will be posting a link to this webinar online. So if you wanted to review it again, or you have colleagues that weren't able to join us and that you'd like to share it with them, please do. Based on demand, we will likely run more live webinars going forward, but we'll wait until next week and see what kind of demand there still is. But please stay in touch, and we will be hopefully able to help you get going with using virtual care in the coming weeks. Thanks very much, everybody. Christine, any parting comments?
No, just that. So thanks everyone for joining us. And I think we're at the beginning of this adventure, and I think if we can all support each other and share ideas, I think there's already been a lot of collaboration. So I'm looking forward to learning as we go. Thanks everyone.
And this, again, has been recorded, and we'll make sure everyone gets a copy of the slides and the recording. And as information changes, check our website. Everyone that has to get to clinic or to office, you're more than welcome to drop off. We're going to do about a few minutes of silence, put everyone on mute, and then we'll come back on and take a few more questions.
At that time, we can probably open up the lines too.
Yeah, thank you. Dr. Sambor, as people are starting to drop off, I see quite a few are dropping here quite quickly, so that's good. One of the pressing questions I also seen in there is, what do you do, maybe Carol can help with this too, but what are we doing with patients who are stuck overseas or patients that are trapped in another province and can't get back? Any advice to your colleagues on if you have a patient that's actually not in province?
Yeah, so that's great. We did get an email communication last night from the CMPA around that, and they were saying as long as they are from here but just trapped overseas on vacation or whatever, that we can still we have to sort of inform them of jurisdiction, but we can still provide telehealth in that situation. They said that if there's Canadians abroad that are living abroad, that CMPA would not specifically cover those situations. So there might be some insurance questions that or additional coverage that people may need to obtain.
Christine, I actually was dealing with a situation in the reverse yesterday, talking to a physician who's trapped overseas, but still wants to be providing care to his patients.
Yeah.
Is that going to be an issue for CMPA?
That's a great question. I think the spirit of it is if you're licensed here and you're you're talking to people within jurisdiction, I'd imagine that's fine. But that would be something to clarify with CMPA. But yeah. Great use of your time when you're stuck abroad.
Exactly.
Yeah, interesting.
Thank you. We still have about 350 people on the line, so we're not going to unmute everyone. That might be a lot of background noise. But Dr. Leong, Dr. Key Leong, I think that's Leong Sit. I think we're just going to unmute you. Can you hear us, Dr. Key?
Are you muted on
You
your
might be
end?
muted.
Possibly. There you go. Now we can hear you.
Okay. All right. So my question is, I don't know whether it's been asked, what is approximate the cost for getting into virtual technology? The monthly cost for going into virtual technology?
It's really variable depending on the platform that you choose. As I
Okay.
mentioned earlier, some are free.
Okay.
Some, I don't know them all by any means, but recently I've heard of some that are $200 a month. So
About $200 a month?
it really depends on the platform you choose.
I see.
Yeah, so there's some free ones, like, for example, like DocsyMe has a free version, and then if you
Right.
want to have more functionality, like attaching
Yes.
documents, you can pay a bit
Okay.
more.
Right.
We pay about $50 a month to $100 a month, depending on, so it should be kind of in that range. And I think the toolkit, again, I don't think it has exact prices, but it'll show you which things are free, which versions
Sure.
are free. So there's quite a comprehensive list.
Yeah. Okay. The other question is how long it takes to get it set up, approximately?
I have colleagues that, we set them up very quickly. In fact, within a clinic, I can just set everybody up. So I know all the vendors are acutely aware that they need to get people set up quickly. So it's pretty streamlined. Some of the free tools, you just basically log in and make your own little web page, and then you just give that link to your patient. So I think it can be done pretty quickly.
Okay. Thanks so much.
And just for the costs as well, we have a lot of EMR vendors and technology vendors reaching out to the doctor's technology office, waiving fees, reducing fees. It's changing by the minute. So do reach out to your vendor or reach out to the DTO. The address is on the screen right now, and we can help you give the most recent information that we have. Michelle, I see you've got your hand up, so we're just going to get you off mute. Michelle, you might be self-muted. There you go.
Bridget, it's really hard to understand you.
Hi, can you hear me?
Yes, we can.
Hi, thank you so much for this really informative session. We really appreciate it. I was just wondering if after speaking to a patient on telehealth, you deem it necessary for them to come in for an in-office visit. How do you, let's say they have to come in that same day, how do you bill that?
So before COVID, I would typically try to do my telehealth in the morning so that if I did need to see a patient, and it's actually been the rare exception, I've been able to see them in the afternoon. And then you just bill the in-office visit. You can't bill both the telehealth and the in-office visit, but the in-office visit is quick, right? Because you've already taken the whole history and then you're just following up with the physical exam. Might see them next day if it's not urgent. So I think about that workflow. Of course, that's going to be changing and shifting according to our manpower issues, and so colleagues are kind of helping out seeing patients, and in which case they can bill the visit as well.
Okay, thank you so much.
Welcome.
Mary? Oh, we had Mary with her hand up, and then we've lost her. Astrid?
Yeah, I don't see it anymore either. It's disappeared. Oh, there you go. Mary, I unmuted you on our end. Are you unmuted on your end? There you go.
Hi.
Hi.
I just have a question about the Zoom licenses, that the announcement that was made a couple of days ago, and I'm just wondering, is Zoom a telehealth platform?
Yes, Zoom is a virtual video conferencing solution, and I believe it depends which version they have. So they do have one specifically for healthcare. It's not a free version. There is a free version of Zoom, but the paid version of Zoom also includes secure messaging.
Okay, but both versions of Zoom, like you can actually have a patient-doctor visit?
Absolutely. We're
Okay.
actually using Zoom right now today for this webinar. And we use it at Doctors of BC internally for all of our meetings. We use Zoom and we can all be in different places and talk as if we're in the same room.
Okay. And you can see each other as well?
We can.
Okay, thank you.
Astrid, there seems to be some issues with my audio. Can you help with the hands up for now?
Yeah, so I'm gonna unmute Ticinda Situ. So if you want to go ahead and talk or and unmute yourself on your end, there you go.
Thank you for a great webinar. It was most informative. My question is, can we bill a telehealth visit for a WorkSafe BC patient?
I believe you can, and I will get confirmation today and post that information on the website. I know that Doctors of BC, we have not been directly involved in that, but there are others who are dealing with WorkSafe. And as far as I understand, they have agreed to honor all the teleconferencing or telehealth codes that, you know, on MSP for the ministry. WorkSafe will also use those.
Thank you so much.
And then I have one more hand up for Dr. Ki Leong. I'm gonna unmute you. If you want to go ahead.
Yes. Can you hear me?
Yes.
Yes.
Yeah. All right. The question is, when you have to screen a patient who has suspect COVID, does the physician have to put on protective gears of all kinds before seeing that patient?
Yeah, and I think that's where you know, the virtual is very helpful to plan ahead, and the broadcast emails have been so helpful to clarify the process for patients. I think anyone with cough and fever, where we are, I mean, we've been instructed if you're just in the room with a patient and you're 2 meters away, you can just wear a mask. We've put on a respiratory precaution sign on the door, so no doctor will accidentally go in. But if you're in close contact, you should be wearing your protective gear. But again, if you can kind of pre-screen the patients, so you have more information about why they're coming in, whether they actually need to come in, because of course now for mild and moderate symptoms, we don't want them to come in the office. We just want them to self-isolate and stay at home and stay healthy and keep them away from our offices. So that pre-screening, I think, is very helpful.
No, I'm talking about already been pre-screened, and there are signs that the patient need to be checked, or the lung need to be examined and things like that.
For example,
so
what this
that's the kind of patients that I'm talking about. And also, after using the room, how do we disinfect that room for other patients, because we have limited rooms for examination?
Yeah, so there is a actual, there's a pandemic office planning guide. I can try to post it, but it actually goes into some quite detail about what you can be doing in the office setting. So we personally have just had a separate garbage for each of our PPEs, and we put them within the garbage, a separate garbage. And there's certainly some guidelines on wiping down surfaces. I think the important thing is if the patient has done hand hygiene and has their mask on, the risk of them distributing their droplets within your room is quite low. We obviously still do the extra step of disinfecting all the surfaces, but there are clear guidelines within that pandemic plan. And maybe Carol, I know it's not kind of specifically about virtual care, but we can maybe share that document.
Yep, we can make it available through the Doctors of BC website, probably. If not, we will make sure that we get it directly to you.
One of the concerns I have too is, like, say, for screening patients who needs to be having a swab. Currently, our office don't even have the swab we have requested. So how do we go about screening those patients? And also, where do we send them? So far, we've been sending them to emergency if they really have trouble. And what I'd say to the patient is stay in the car, have a healthy person take you there, and then the healthy person go inside with the mask and ask the nurse to come out or someone to come out to help that person. So how do we get those screening done?
You know, so again, I think the screening has changed a little bit in the last few days. So we're not trying to screen everybody in the community. We're really trying to focus on healthcare workers, people that require hospitalization, long-term care, specific clusters.
Okay.
For the most of the patients, yeah, it's completely changed in the last few days. I'm just talking about self-isolation. I do have that little information sheet for patients, which I'm attaching or emailing to them, especially if they're within the household.
Okay.
And then locally, you're going to have your own resources. So those are questions, and I think that you know, maybe perhaps we can link you with some of your what region are you in? What region are you in? Are you local here in Vancouver Coastal, or are you in a different health authority?
The alarming thing is we're seeing doubling of the cases every 2 days, and I think it's right that it's past screening now. I think we probably will have to have a lockdown to get this control, because it's like a wildfire spreading everywhere.
Yeah, and in terms of that, again, I think it really motivates us to make sure that our vulnerable patients are well taken care of as they're isolating at home, because we're probably at that.
Yeah. So far, I've been taking care of patients through phone calls and trying to avoid going to the office and having them not come to the office if possible. Yeah. So this is what I've been doing. But the thing is, though, is personally, I think we're going to be having a lot more problem before it comes down, the way it's going. And we're going to be buying more ventilators. We're going to have the ICU plugged up. Unfortunately, this is my prediction.
If I was you, I would check with my local, check with your local division of family practice. They will have a good sense as to what the plans are in your community and how to make sure that you are referring people to the right testing sites, etc. Right.
Okay. About 10 days ago, I have been emailing actually I emailed even the Prime Minister Trudeau and also the health ministers and so on about my fear. And I get virtually now not much of any response, except the Prime Minister emailed me back and told me your concerns have been sent to the Health Minister of BC. And then it was yesterday or 2 days ago that I got a response. It was the 6th, I think the 6th of March, I sent the email of my concerns and didn't get anything until yesterday. And so they give me what I get is a list of what we should do, which we already know: wash hands, social distancing, and so on and so forth. But then 10 days ago, there were virtually very little cases then. So we just see the cases climbing day and day and day, and now deaths. Okay, so that's my concern.
Mm-hmm. Carol, it's Bridget. I just want to let you know that Dr. Ross has her hand up as well, just in case she's chiming in on this conversation. I'm not sure.
Yeah, I'm going ahead and unmuting her.
Yeah.
Can you make her a panelist?
Hello, Dr. Ross.
Hi, good morning. Can you hear me?
We can.
Okay, perfect. So thank you very much for raising that last question. This, I can assure you, as the president of Doctors of BC, has been foremost in my brain 24/7 for the last 4 weeks.
Yeah.
You're quite right. We've seen this coming. We knew what was coming. We've done actually better than some other jurisdictions in blunting the curve, and time will tell. I've been working very closely with both the divisions of family practice and the medical staff associations to ensure that we are indeed ready. As far as the number of ventilators go, we've got lots of plans in place within our facilities to use other respiratory support devices. It's not all about ICU beds and ICU vents. It's about physical space and trying to keep as many people as we can at home We've heard cases where it obviously progressed to pneumonia and worse. And really the plans vary depending on where you are. Now we have tried very hard to coordinate with Pathways to ensure up-to-date information about screening in your particular area is actually available on the banner on Pathways. So you can certainly have a look there, connecting with the division as you had said. And then each of the health authorities has it as an emergency response plan that's been shared out across all of the physicians that have privileges, and also with the community physicians. So it is on the physician website for all of the health authorities if you have concerns around their emergency response plan. And did that address all of your questions for the moment?
The one particular one that I find would be very useful is that we get to know where to send patients who absolutely need screening,
right?
What's their phone number and where, because this is what doctors a lot of doctors don't know what to do with us.
And I appreciate that. Where are you? What
I'm in Richmond, British Columbia.
Okay, so actually if you go onto the Richmond Division of Family Practice website, there should be a banner that directs you to the coronavirus testing platform. The way that the majority of them are running is that there is a virtual online screening tool that patients will fill out, obviously highlighting the prioritized areas as soon to be hospitalized, which includes late trimester pregnant women, hospital workers, and those with sufficient signs to be tested. At our screening, at our virtual screening platform across from Royal Columbian Hospital, we had 160 plus people fill out that platform yesterday, and only 17 met the criteria for testing. So the idea is to send everybody for testing, but to rather prioritize those ones that we need to know to control the spread. Everyone else is being asked to self-isolate. So that information should be on your practice website.
Sure. The self-isolation we already know, and that's what I'm encouraging everybody that I talk to, my patients, to do that same thing, and not to walk around in the street or not go to malls and all those things, and to wash their hands and so on and so forth. The main thing though is we still see, I'll just give you an example. I have a patient who the cleaner comes to the house to clean every 2 weeks and so on. And the cleaner is also a caregiver. So she's given care twice a week on an elderly patient. And recently the caregiver is tested positive for the COVID. So now, not the caregiver, the elderly person. So the caregiver now has been asked to be checking who she's been in contact with, and still she hasn't been tested. They say you still have symptoms. You don't have symptoms, but you don't need to screen.
If people are asymptomatic right now, we're not screening them. Now you're not wrong. Sometimes people are going to be shedding virus ahead of it. But if you look at how we contract this virus, it's actually somewhat difficult to contract. This is large respiratory droplets unless we're doing an aerosolized procedure. This is something that can land on hard surfaces, so you might be at risk. But good personal hygiene practices of frequent hand washing, not touching the face, putting a physical distance between you and someone who is ill. I think cleaners are actually more experienced at this than physicians are actually. Because they've been doing this for a while, and this is not their first virus they've been exposed to. So
it's Bridget.
Okay.
We've just got a few quick minutes left, and I still have 2 people with their hands up, probably with a burning question of their own. Would it be okay if we just followed up offline if need be? And
that is totally fine. Yeah. Let somebody else ask questions.
Thank you.
All right, thanks. Sorry about that.
Astrid?
Okay, so I have Paula Aiken. I'm going to take you off mute. Oh,
hello.
Yeah, we can hear you. Go ahead.
I just wanted a quick question. In these days where we're being told that a large percentage of the spread is happening with asymptomatic carriers, should we be using personal protective equipment for every patient that requires a physical exam? So if we're seeing somebody, we're doing an abdominal exam, we're doing some kind of an internal exam, we're Also, should we be deferring things like pap smears, those types of things, or should we be doing those things using for personal protective equipment, or is just a mask and gloves enough? Also, do we have to change personal protective equipment between each patient so we're not transferring from patient to patient? That's it. That's my questions.
I can briefly chime in that we're certainly looking at deferring non-urgent things like PAPs. Lots of questions come up like, what do we do with our allergy shots? What do we do with our, our child immunization? Like, would they be safer going to the public health unit for that? So we're having lots of conversations about things that we can defer.
With respect to everybody that's on the line, I think you all have a lot of burning questions, and I totally understand the need, but this session is about virtual care. It's not about all practices around how to practice medicine in today's environment. So maybe we need to suggest that there be another forum for physicians to have these discussions.
Good idea.
Yeah, so I have one more hand raised. Hanan Farag, I'm going to take you off mute if you want to go ahead and speak.
Hi, thank you for the very helpful session. If I have a patient, I'm doing virtual assessment, and if they have a general, as a flu, they have flu, do I ask them to self-isolate for 14 days as well?
Virtual care.
Yes, so you're and we're having that conversation a lot with patients. There is a document that we can send patients that will actually outline what those self criteria are. Understanding that yes, we ask those patients to isolate for 14 days, but we can maybe upload those or share those documents.
So anyone, basically, so everyone will be self-isolated for 14 days, even if it's just a flu, right?
That's my understanding. If they've got fever and a cough, we're not sure what they have. So, but again, that I would probably leave that, defer that to the experts.
Okay, thank you.
Okay, then I have another hand up here from Jocelyn Cower. So I'm gonna take you off mute.
Can you hear me?
Yes.
Yeah, my question is, anybody with cough and a fever, wouldn't you really want to listen to their lungs, make sure that they're not developing pneumonia? So half of your virtual visits will end up in being in clinic visits?
Yeah, I mean, it's true, but I think also, so first of all, you're going to screen which patients are mildly ill and leave them at home. You can, so we've had these situations where I just didn't like the sound of how people were doing. Of course, we have to assess them or make arrangements for them to be assessed. But then we can take appropriate precautions. We are ready for them. We can keep them away from our general population at the office. You can have everything ready. So I think that pre-screening piece is really very important to keep ourselves safe and our other patients safe. But yeah, absolutely, we have that duty of care. Don't forget, some people might have influenza. They might be someone that you would typically give, Tamiflu to. So you do have to be making those assessments. So yeah, some of those patients ultimately are seen in the office, but then we can do it in a really controlled manner.
Right. I work in a group practice, and we are a group of 6 GPs working. What we are actually trying to do, and please correct me if we are doing wrong, is that chronic medication refills, we are trying to do that through virtual care, whereas people who are low risk for corona, but again that's just not not a thing anymore. But we are trying that if we feel that this patient could be sick enough, we are asking them to come in, but obviously then we are putting ourselves at risk too.
Yeah,
Hi, it's Bridget, everyone. I just want to reply that it's almost 8:30, and I can't remember if Dr. Sambor had an appointment at 8:30 with any of her patients, and she's practicing as well.
For time. Yeah, thank you for checking in.
Okay, we have a few more hands up as well, just so you know.
Ask away.
Okay, the next one I'm going to take off mute is Candice Quayton.
Go ahead, Candice.
Oh, can you hear me now?
Yes.
Yep.
All right. Thank you so much. I think this has been a very valuable presentation. I do have a question about how we can advocate within our own health authority. So I'm a specialist in pediatrician in interior health. And we have a pediatric outpatient urgent care clinic that's really about like hydration follow-up, emergency department, urgent follow-up. And we've been asked by Interior Health to facilitate that as can be done with virtual visits, but they've had really strict regulations on what platforms have been fine. And I'm struggling as the millennial in the group to bring a bunch of people who are unfamiliar with virtual visits into something. And I really liked your emphasis on using what works for you. How can I emphasize that within the Interior Health organization to use what works for us?
That's a really good question. I've been working with the health authorities primarily through PHSA.
Oh, sorry, I'll turn you down so you don't echo.
And the health authorities definitely are much more risk averse than those of us in the community. And so they are putting in many more restrictions than I would like to see happen. I don't have any specific advice for you other than I will try to talk from my end to my colleagues in IMIT in the health authority on your behalf or on behalf of all the physicians in Interior to see if they could loosen up their guidelines and particularly in this particular time of emergency to see what we can do differently. But I know what they're trying to roll out, I believe, through all of the health authorities is Zoom. So it actually is a pretty good platform, but let me check on that and I can actually get back to you. We have your email address from the attendee list. I'll see if I can get back to you on that.
Perfect. Thank you so much. I appreciate it. Have a good day, guys.
Thanks.
Okay, I'm going to take next Roderick Densmore off mute. If you want to go ahead.
Hi, it's just a quick question, just a practical one. I need to figure out how to get fax capability going. And so how viable is eFax? Is it secure? Is there an eFax that people have actually used that's reasonably easy to set up on a Mac? Those are my questions.
Christine, do you have answers to this?
I'm not a big expert on that. We do have eFax in the office and we've been using that. I know a lot of EMR vendors are quickly trying to incorporate that within their software, but I'm not an expert on what the devices are. So that's an excellent question to bring to our technical team, and perhaps they can connect with you offline. And if there's enough in that, we can post that to the group.
Exactly. So we'll have somebody from our technical team follow up with you.
Oh,
and
that's
Kathleen,
great.
I left you unmuted so you can join in the conversation anytime.
Okay, thank you. Sorry, I didn't know that. I'm running around getting ready for the office. So what our office has chosen to do is set up a don't reply to email address because the patient has already consented to electronic communication, including email. And then we save to PDF whatever we have in our EMR, paste it on our desktop, and then send it from the don't reply to email. And so far, that's actually worked pretty well.
Great. Thanks for the suggestion.
Okay, then I have another hand up here. It just disappeared. Sorry. Then one came back.
I think we can only take 2 more questions, and then we have to let poor Christine get back to her office.
Okay, so
or
Marissa
back to her
Collins.
patient.
It may have partially been answered by the last question, but I was trying to figure out how to unmute myself. Sorry about that.
That's okay.
My question is that I'm doing mental health groups as a sort of GP consultant. So people are referred to me by a family doctor or sometimes even a psychiatrist. And we do an extensive mental health questionnaire before we see the person for an intake session to see if they're even appropriate for the groups that I run. And so just trying to figure out an easy system of, ordinarily they'll complete that form and bring it with them to their appointment, or yeah. And so what do we do? Or we have forms there at when we see them. So if we're no longer seeing them as groups because of what's going on, and the facilities I work in don't allow groups anymore, any suggestions on how we can go back and forth with those forms? Some of our patients are older and not able to download, complete, and resend. So it's a difficulty. Mailing, I don't know. I mean, verbal consent I'm okay with doing, and then have them mail me the completed consent form, but I don't know how we're going to do our intake questionnaires.
Yeah, typically I would say that they could scan it and send it back to you. If they don't have that capability, then it's challenging for sure.
I suppose they could just take a picture of it, like most mobile devices have just a scanned document. But yeah, those are the sorts of things. If someone comes up with a great solution, this is the time to share. But we're trying to make things as easy as possible for patients. Yeah. And as far as my elderly patients, my elders, they have taken up this technology like so quickly. I've been so surprised. So I don't think we can't assume that some of our seniors are not capable of doing these things. And
no, but I know that many of my clients aren't.
Or adult children can help them with some of that as well.
Yeah. Okay. The isolation
that is a great suggestion, Christine, to just take a picture of it and send the picture.
Okay. Yeah, it's a partial solution. I may have to do just individual, much longer sessions with them.
Yeah.
Okay. Thank you for an excellent session.
Thank you.
Thank you.
Okay. One last question.
Yeah, I have one last hand up, Hanan Farag. So I'm going to unmute you if you want to go ahead.
Sorry, I might have done it by mistake. Sorry.
Oh, that's okay.
So are we done? No more hands up?
No more hands up.
Okay.
Wonderful. Well, what a great conversation.
It was.
The first of many.
Thank you so much, Christine. And thanks to all the participants. And stay tuned. We'll have more to come in the coming weeks.
Thank you.
Thanks, everybody. Bye.